This is Chapter 31, Part 3. The Ilizarov external fixator. This is how we treat a short limb, and usually a leg. We can lengthen a leg this way. It uses wires and rings and telescoping rods, and we make a percutaneous ostomy that creates a false growth plate. We're able to make the bone grow about 1 centimeter a month, but the most we can get is about 15 centimeters. And we are going to teach the child how to use crutches while they have this on. And I have a picture here. You can see it's pretty big, and they're going to need some help with their balance and crutch walking. These rods in here are what we lengthen, that then works to lengthen the leg. Developmental dysplasia of the hip. We used to call this congenital hip dislocation, but not every one is dislocated, so we've kind of made it a more encompassing title. So what happens here is prenatally the hip doesn't develop right, or the head of the femur is not inside the acetabulum, inside the joint. And some of the physiologic factors that go along with this is maternal hormones, which are loosening all the maternal joints for delivery, can affect the fetus, and intrauterine positioning. If the baby's developing in a weird position, it's got that hip not where it should be to develop inside the joint. Mechanical factors: breech presentation, multiple fetuses, not enough amniotic fluid, and a really large fetus. Our most typical presentation is a first baby, so the uterus is tighter, it hasn't been stretched out, breech presentation, and female. That's what usually we see. There are genetic factors. This is something that happens. Certain families will have a higher incidence of it. The sooner we treat it, the better our outcomes, and also the less invasive the treatment. Between birth and 6 months, we can just have this baby in a harness. It's really not that inconvenient, and we have very good outcomes. It puts the hip into the joint the way it should be, and they walk normally. If we don't get it treated till 6 to 18 months, we may need traction and casting, and we might even need surgery. So a lot more invasive, and our outcomes may not be quite as good. We may have a limp or some abnormal gait. If the child's older, we're talking about needing to do surgery, and we're certainly going to have at least a limp, not quite as good of an outcome. Here's what our normal hip should be. This is the reason we call it dysplasia now instead of dislocated, because this one's in the joint, but the joint's not quite right. See, the shape is different, so it's going to predispose us to not work right. Here we've got a subluxation. Our tendon is being stretched. Things are not where they should be. And here we have a true dislocation. It's not in the joint at all. And the way we find this, we want to look at the gluteal folds on an infant. They should be symmetrical. So if there's a crease here, there should be a crease here. They should be equal, and by running the hips through their range of motion, we're listening for a hip click. And then on a little older child, we're going to have them stand and watch how they stand and watch their gait. This is the harness that holds the joint in its right position while it develops. And you know, this is an infant who likes being held anyway. It really is not that inconvenient, and they can be dressed and diapered and held and loved just like a normal baby, and we have good outcomes with that. Now, congenital club foot. This is a foot that develops abnormally, and usually this is from an abnormal position in utero, although sometimes there's some sort of other things going on, but usually it's just from positioning. And we treat this by casting. Every week or two, we're going to push the foot a little more towards normal and cast it that way, and push a little more towards normal and cast it that way. This is what we usually start with, and like I said, we're going to push it as far as we can. We don't want to cause any sores or anything though, and cast it, and then a little more and a little more and a little more until we get a normal positioned foot. Now, limb deficiency, amelia, which is absence, maramelia, partial absence, focamelia, this is looks sort of like a seal limb. This is where the hand or the foot develops normally, but the arm or the leg is extremely small, so it almost looks like the hand or the foot comes straight off of the body. We can also get problems with limbs developing from a band in utero. Some sort of amniotic band twists around it and prevents blood flow and normal development of the extremity in utero. Most of the time though, the reason we see this is from some teratogenic thing that mom took, some medication that she was given in the first trimester when the extremities were developing, and that's the usual cause. And managing this, prosthetic devices, there's not much else we can do. Osteogenesis imperfecta, this is also called brittle bone disease. That's kind of the lay term for it. It's a hereditary disorder. There's a number of different types, ranging in severity from not too bad to extremely severe. The underlying pathophysiology is that they don't produce collagen. Collagen's a component that we need for bone structure, and because we're not building these normal bones, we get demineralization, which makes the bones break more easily. So we're going to see fractures, we're going to see osteoporosis, and we'll end up with some skeletal deformities from the fractures and this abnormal bones. We do see an improvement after puberty, less fractures. We treat it with medications to promote bone density, and then supportive care, being very careful in how we handle these kids when we're diapering them and dressing them, and in severe cases we may have to do surgeries and put rods in the long bones if they're just repeatedly having fractures. Leg Kpyhosis disease, this is it's not from infection, but we get a necrosis of the femoral head. It usually happens in boys, usually between 3 and 12 years old, and in fact I think it's usually like 6 to 8. They get a flattening of the upper surface of the femoral head, then vascular reabsorption of the epiphysis, and then finally regeneration. It usually regenerates on its own, may take a year or more though, and they're going to have some pain during that time depending on how severe it is. We may be able to just have them rest and not use it. We might have to go to traction or braces, sometimes even to surgery. Slipped capital femoral epiphysis. This is when the femoral epiphysis slips down and back, so posterior and inferior. This usually happens right before the accelerated growth of puberty. It slips and gets this deformed femoral head. This requires surgery and pinning it in place. So before surgery, we're going to have these kids on bed rest, and we're going to have them in traction, and then they'll go to surgery. Kyphosis, lordosis, scoliosis, this is abnormal curvatures of the spine. Kyphosis is that dowager's hump, so bending forward at the thoracic area. Lordosis is an exaggerated curve of the lumbar area, so sway back, and scoliosis is kind of twisting to the side. It causes cosmetic problems. They look funny, but it also causes physiologic problems. You're pinching or pulling and stretching different organs. We can treat it, try bracing, exercise, try and strengthen those muscles that hold the spine straight, and if those don't work, we go to surgery, which is spinal fusion. After that spinal fusion, pain is a problem, so post-operatively we're working on controlling pain, at log rolling them, taking good care of their skin, and We want to do good neurovascular checks because, I mean, this is all our spinal nerves that we've done surgery near, so we want to make sure there isn't any compromise, swelling that's hurt damaging nerves or circulation, and checking circulation and vital signs. And after surgery, we ambulate them early. And they have a spine in there, a rod in there, it's stable, we can get them up. Here's what our spine should look like. Here's the Kpyhosis, here's the Lordosis, and here's the Scoliosis. You can see with the Scoliosis, the scapula are uneven, the shoulders are uneven, and if it's down a little more lumbar, the hips are uneven. And this is what you'll see when you have them bend over to touch their toes and come up slowly. You see a big bump where it is. And here's an x-ray showing a pretty bad scoliosis, and here are the rods after surgery. Here's the brace. Okay, osteomyelitis. This is an infection in the bone. Can get directly in there or can spread from some other place. What we're going to see lab-wise is elevated WBCs, and we're going to see an elevated SED rate. At Children's, they tend to use CRP as opposed to SED rate, but both of them are labs that show that our immune system has been turned on. They're probably going to run a temp, may have localized tenderness, swelling, warmth over the involved bone. It's painful. In fact, a lot of times kids will not walk. Kids who have been walking or crawling will stop. The treatment is 4 to 6 weeks of IV antibiotics. Most of our cases are caused by staph, which is a germ on our skin, and somehow it gets under the skin and then settles into the bone. Initially, we're not going to let them bear weight, but after that, it's fine. We just continue the IV for 4 to 6 weeks. Bone tumors. 3 different ones we're going to look at. Osteogenic sarcoma. This usually happens in teenagers between 10 to 25 years, and it's in the long bones usually, and especially in the femur, and we almost always have to amputate. We're going to resect the tumor, and like I said, that's usually amputation. Give them chemo. Survival rate's about 85% as long as it hasn't metastasized. Ewing sarcoma, this is a tumor that occurs in the bone marrow. So we're going to do radiotherapy or radiation and chemo, and we have about an 80% 3-year survival rate. Rhabdomyosarcoma, this is soft tissue, tumor in the soft tissue. We're going to do radiation and chemo, and this has about a 65% survival rate. Juvenile idiopathic arthritis, we used to call this juvenile rheumatoid arthritis, but a lot of kids, their rheumatoid panel will be normal, and it's idiopathic. We don't really know why it happens, so that's the better name. What happens is they get inflamed joints, and unfortunately that inflammation in the joint can lead to permanent destruction of the joint, permanent damage. This usually lasts a year or more and kind of resolves on its own, but whatever damage has been done is done, and that damage doesn't go away. So our first line of treatment is going to be with NSAIDs. They have swollen, painful joints, so that'll help with inflammation as well as with some of the pain. If that's not enough, we're going to add methotrexate to it. If we're still having problems, we're going to add corticosteroids. Physical management, moist heat feels good because this is painful. Pool therapy, and we're trying to preserve function by maintaining muscle strength and joint mobility. And some of the clinical manifestations we're going to see: stiffness, swelling, tenderness, pain. Although some kids aren't that painful, warm to touch, but it won't really look red, but they have loss of motion, and they'll complain of stiffness in the morning or after a period of inactivity.